working with Moorfields Hospital Center, Abu Dhabi. Hope we all are on and you're done with the pre-test. Now let's move ahead. So today we'll be talking on the history taking. Basically, mostly we'll concentrate on the ophthalmic history taking, the patients on the ophthalmic clinic. Now, first, if we go with the objective of this one, we'll try to get an overview and understanding what history taking is all about and what are the things which are important component of the history taking, and what should be a normal approach to the history taking and how that helps in normal clinical practice. So what is medical history taking? Basically, it can be any information which can be related with the past or the present of the patient that can be helpful for the clinician in the patient care. So it can be related with his habit, it can be related with his other accessory things, it can be related with his family members, but if it is relevant to the patient care, that can be a part of the history. So in it's basically a kind of interview where we ask, or the clinician or the person who's taking the history asks the patient about what's the purpose of the visit, why the patient is here, what kind of limitation or the difficulties he's facing, and if there is any similar kind of situation, or if there what is the general health condition or any similar kind of past experience, all this kind of issues that we try to get the retrieve or the information as much possible through the history or through the interview. Now, why the history is important? It helps us in many ways. First, it helps us to understand why the patient is here. Definitely, this is not a tourist place that patient will just come to meet us and greet us. It's not that. They are in some issue, they have some problem, so they are here to get a solution to their problem. So it helps us to find their need. It helps like how that condition, whatever the condition is, how that is impacting in their practical life, how that is influencing or limiting their daily functionalities. So it helps to understand that part. It also helps us to understand or design like what are the subsequent steps that we should take based on the history. For example, based on the history itself, the clinician may decide if the person should go for x-ray or CT scan, or there's like just as an example. And at times, or many a times, a good history, if the history is complete and informative enough, it helps to make the diagnosis much easier, or sometimes we can conclude like there are studies which suggest that it can go even up to 60%, 70% of the time based on the history itself. We are very close to the diagnosis. So that's why the history is very important. Now, what are the usual components of the history, or what are the things that we'll be looking in a history? There are few basic things which are common to all the histories. It can be a personal data, the chief complaint of the patient, the past history, and in our case, we'll mostly consider the ocular part, and past medical history with the general health conditions and what are the implications on that. And if there is drug histories like drug uses or allergies, then the past history of the surgery or trauma, and the family history and social history. We'll look into these categories a bit in detail in subsequent slides. Now, why the personal data is important? First of all, personal data with the name itself, that helps in rapport building. If I'm going to ask someone something, it is very start, or at least I'll be, say I'm the patient, I'll feel more comfortable if the clinician is addressing me with my name. Uh, then like that helps to connect immediately. And there are conditions which are related with age, or the age specific diagnosis or differential diagnosis. So the age is also an important component in that. And there are few conditions which can be gender specific. Few general health conditions, or few ocular conditions, which or any clinical conditions for that matter, are more common in one particular gender than the other. So this is why this personal data is very important, and we need to look into that. And another part is we don't want to mix match the history and the patient. When we call the patient, that is another reason that it's just a double check that we are calling the right patient for and we are getting the right information. because if the information that we are getting is not correct, it will subsequently affect the whole process. Now, in the chief complaint, what it would be is the chief complaint is a very quick summary of what the patient has come, why the patient, what's the purpose of the patient's visit today. Once we get that information, we can ask, like, if it is a regular checkup, or if there is any specific issue that brought you here today, or if what's the condition that you are here today. There are several ways that we can ask on that. And once we get that information, like why the person has come to the clinic today, there are several questions, subsequent questions. Maybe all of them we can use, or some of the questions that come subsequently, which we can put as an acronym as folder, with a instead of E in the folder spelling. Now, what this folder stands for is the frequency, like how frequent, whatever the complaint is, how frequently that is happening, and the onset. So when did it start? If it started just recently, or it started say a couple of months back or years back, since when the patient has this same kind of issue. And location. Say someone says, I have a pain. So pain, where is the pain? So that location is also important. And then the duration. So since when it is happening and how long does it last? So duration will give us both the options. So we need to confirm, because certain conditions, it may come and go. And some conditions, it is persistent, like it is there, continuously there. So if it is changing, if it is like how, like this frequency and this duration, how long does it stays little different. Like frequencies, say for example, I'm getting visual aura. So how frequently the aura is, or I'm getting double vision. So how frequently the double vision is. And the duration is like how long that persists. If I'm getting say little, sometimes the vision is little blurred. So how long that duration is. If it is for a few seconds, or if there is a blackout. If there's for a few seconds, few minutes, or hours, that is the duration. And there will be some associated factors with all the conditions on the remedies. If we have some idea, like if I say for certain conditions, if I take rest, it goes off. If I sleep well, it goes off. Or if I need to take medication for something. So these are the part of the chief complaint that we may need to ask subsequently. Now, about the past history. Past history can be on two basic category. One is about the current problem, like if there is any similar episode of the same issue before, and if it was there, what was the diagnosis at that time, or if what kind of management was given, and what was the outcome, so that it will help us to understand if the similar uh, approach can be taken or it has to be different. And other part is the past medical history, which is more of a general health condition or general health related. Like if there is any systemic disease like diabetes, or hypertension, or thyroid diseases, their duration, like since when they have, like certain diseases, longer they are, the effect will be more profound. And stability, if the disease, say someone is having a diabetes, but that is pretty stable, then very less likely that will cause any major impact. But if someone's having a diabetes, say for less duration, but it is very unstable kind of, then the effect or the impact of that on the other conditions will be much profound. So that is why any systemic conditions, their duration and stability is important. If there is any medication that they're taking on regular, with the doses, because some medication affect the other parameters, or some medication cannot be put together. So we need to have that idea. The clinician should get the idea of what kind of medication the person has and what kind of doses they are using. And any history of surgery done, or say it can be ocular or it can be facial. For example, in our case, in ophthalmic cases, if the person did not had any say ocular surgery directly, it was not on the eye, but it is around the eye, which may affect. And if there are any other major surgeries, like if there is any say there was any brain tumor before, or that was got operated, so any kind of surgery, and if there is any kind of trauma. The trauma can be fall, or it can be with something got hit by, or a car accident. That might have happened long back, but that may be important for the presenting case. And apart from that, one more very important part is the allergy. So that we don't want to complicate the things more, and if we know the allergy, we'll try to avoid those category of drugs. Now, family and the social history. Now, why the family and social history is important? As I mentioned already, like there are few conditions which are more common in, or which are seen in the family. For example, color blindness can be seen in the family, or the retinitis pigmentosa can be seen in the family. There are similar other multiple conditions which is very common in the family. So if there is anyone else having the similar kind of condition, and if what is the relation with the patient, and sometimes the patient may not have the same condition, but if it might be very important that if there is a strong family history of that, so it is better to note down, like say even conditions like diabetes, or say chronic heart disease, or this kind of conditions. It is better to keep a note on that, and what kind of management they followed, if anyone else had, or say for example keratoconus. Sometime it is, if it is there in the multiple member in the family, so what kind of approach they had, and that will also help us to understand like what kind of explanation they might need, because if it is there in the families, they have a little bit of idea which some of the points can be correct, some may not be correct. So we need to be a little careful on that part. So that's why this history, or this part of the history, is very important. Now also the social history part, like the habit of smoking, alcohol, and how the living arrangement, especially in the current situation, if we consider in this kind of situation, the living arrangement is very important, which was not there in say other cases. So this kind of things are very important. Like if someone is having pets, someone has a particular kind of hobby, if someone goes for golf, or say jet ski, this will give us some idea about their lifestyle. If there is a sudden change because of their condition which will impact their lifestyle, the person may not like, so we need to modify in those kind of condition, or we may have to adapt to those kind of conditions. That is why this part of the history is also very important. And there are few conditions, or few say treatment plan that can be possible, or that may be having some restrictions based on the lifestyle as well. Say for example, if someone wants to get a laser treatment, like LASIK treatment done, the refractive surgery done, so all the refractive surgery may not be suitable for all kind of lifestyle. So that is why this is very important. And say occupation will give us a little bit of idea about the screen time, and how the person is overall managing his daily activities, so that we can plan our management, or the subsequent visit, and other issues thereof. Now, in here onwards, we are moving more towards the ophthalmic cases. Now, ophthalmic cases, when the person comes to the eye clinic, there could be three major category of complaints. It can be vision related, it can be physical discomfort, or physical issues, and it can be alteration in appearance. Now, when we say vision related, it can be blur vision, or distortions, or decreased vision, or like floaters, black spots, flashes of light. This kind of complaint, usually they will complain. Now, say someone says that I got a blur vision, there will be some certain, from the folder thing, there will be certain specific question we can ask to the patient, like since when the person has this, or like if it is only for limited to a particular distance, and this kind of, we'll go through all of this in detail in subsequent slides. Now, the physical discomfort part, it can be a foreign body sensation, it can be say discharge coming out, redness, like I wake up in the morning, I saw that my eyes are red, or I'm not able to open the eyes, it is sticky discharge. So we can get into those we can get this kind of complaints, and we need to get the subsequent information related to these complaints also. Or it can be, as I said, it can be based on the appearance or alteration in the appearance, which can be related with the ptosis or the deviation. Which is more common is the deviation of the eyes, like the squint part. Someone may feel that the eyes are not straight. When I'm looking straight, one eye goes off or comes in. And it can be like the eyes are not, so the parents may come with a newborn baby, like the eyes are not stable. I see that eyes are moving very much. The kid has a shaky eye. They may explain their issues, their conditions in very layman term. So our questions also should be in that kind of terminologies only. We cannot use, say for example, the shaky eye will be more appropriate, or if the eye is moving out or in is more appropriate in this kind of condition to ask than nystagmus or squint. The patient may not, the parents or the patient may not know what is nystagmus and what is squint. So it is better to ask, when we ask the questions related to this, the person may not know exactly say what is diplopia, so we can ask double vision. So this kind of very basic things. So in discharge, we can ask like what kind of discharge, if it is yellowish, if it is watery, if it is sticky, so or if it is rope-like or thread-like. So this kind of description will be helpful for the clinician to come into diagnosis, or to like at least decide what should be the path to follow. Now, the patient who comes with a vision issues. Now, when someone comes with a vision issues, first thing we need to ask is like this does not go with the exact regularity. Like it's not necessary that you have to first ask the laterality, or but we can ask if the vision is less in both eyes or only one eye, and then if the vision is less at the this far or near or anywhere. And if it is a certain duration, like sometime they will say like, I don't find comfortable when driving or after using computer. So this kind of, if there is any specificity, we try to find out that part. If there was any previous similar kind of episode before, say the person had similar kind of issue and was using glasses and started getting the issue again. So this may imply that there might be a change in the prescription possible. So for the same reason, if there is any history of glasses use or contact lenses use, if there is a history, there are subsequent things that we need to get the information about. If the glasses were for distance or for near or progressive, it's just a quick note that helps a lot. Then if the glasses were used regularly or not regular or not used, like it was given but sometime only I used, the patient may say like, no, I used only occasionally. So but that even the person did not use it enough, but it is important to get an idea. Okay, the person had a glass, so we can try to find out why the person was not using. If there was some issue with the glasses, or the person does not like the glass, or there could be some other reasons also. So that is why this information is also very important. In the similar way, if someone is wearing contact lenses, we need to ask both the physical and the visual comfort. If the person is comfortable with the contact lenses that he or she is using presently, what is the vision quality? How it feels towards the end of the day. With certain contact lenses, if the fit is not well, or if the lens category is not suitable for the patient may not, or the patient is wearing for longer duration, uh, patient may not be feeling very comfortable towards the end of the day. Or if there is a dryness issues, that can also give similar kind of information or response. And the other part is the last update and stability in both glasses and contact lenses. This is also important. This gives us an idea about their refractive status and how frequently they are taking these things into consideration. So for the contact lens user, there are a few other informations that we should know. Is if the person is using a soft lens or a GP lens or a scleral lens. So soft lenses, there will be like daily disposable lenses, monthly disposable lenses. So if we have that information, that will be better. Sometimes the person will say that I'm using a daily disposable, or say I'm using a monthly disposable. But when we ask in detail, then they may say that I'm using, for example, Acuvue Oasis, which could be a bi-weekly lenses, but either they didn't know or they might have missed that information that it is a bi-weekly and they're using for the whole month, which is not correct. So this kind of information is important. And the last use, especially for the scleral lenses, the last use is important because that may change the outcome slightly. The other very important thing is with the vision loss is we need to get two more information. One, if the vision loss is sudden or gradual, because if it is a sudden vision loss, then the implication is different, then the diagnosis could be different. If it is gradual, then mostly, for example, in case of cataract, we expect that the vision loss will be gradual. In case of retinal detachment, we expect the vision loss will be sudden. Or if there is any, say, neural issue, it can be sudden. And the same way, like there'll be, if it is with pain or without pain. If it is painful, then it can be BRVO or it can be like acute angle closure glaucoma, which can be painful. If it is painless, it can be refractive error, it can be cataract like that. So that is why this information is also very important for us to get. Now, we get a lot of pediatric patient, and this pediatric patient information is not only for ophthalmic cases. In my opinion, even in the general peds area, this information will be helpful. Like we need to get the birth history, if the baby was delivered full term or premature, if what's the mode of delivery, if it was normal delivery or C-section or assisted or forceps delivery, any complications during the pregnancy, during delivery or post-pregnancy to the mother and the baby, and what was the birth weight, and if there is any history of incubation or if any ROP screening was done for little older babies, or if there was any ROP which was treated, which is very important. Any history of consanguinity. I understand, like based on the social prospect, in some cases we may not be very comfortable to ask, or the person may not be very comfortable to answer, but this also very important part to know that if there is an history of consanguinity, because there are ample amount or ample conditions which are more common in the contiguous marriages or contiguous offsprings than otherwise. For little older kids, we need to get the milestones. If they started talking proper at proper age, or if they started walking properly at proper age, this kind of information will help us to understand if the overall growth is normal. If all other growths are normal, we expect that visual growth will also be normal, and subsequently if it is not, then we'll try to find out something else. And if there is any family history, especially for kids, the family history is also important. Say, for example, if there is already a history of lazy eye or any, say, high myopia or things like that, so we can that can help us to set the course of the examination, and like what kind of how frequently the patient should be seen again. So this kind of decision making will be much easier with this history. Now, patient when they come with the squint part, now, this is little odd at times, because what the patient may say or the parents may say, "Oh, my kid has got squint," but actually they don't mean squint; they mean the squeezing of eyes. So we need to, if they say squint, it is better that we just confirm once with them again. By squint, they mean the deviation of eye or squeezing of eyes. Because if it is squeezing of eyes, it is different. If it is deviation, then the subsequent questions or subsequent information that we will need is different. Say, for example, if it is deviation, then we need to know if the eyes are moving inward or outward. If the deviation is always one eye moving in or out, or both eyes, or sometime right, sometime left. So that will give us very good information or very good clue about the condition. And if that was noticed since birth, or it gradually developed over time, or there are any condition like any trauma or surgery after following that, the person is getting this kind of issue. So this, say for example, some kind of trauma can lead to squint and diplopia. So that is very important for that purpose. And there are certain health conditions, for example, myasthenia gravis or thyroid diseases, which can give at times give squint, or it can alter the presentation of squint or the frequency or how much the squint will be, that all these things can differ. So this is very important to get the general health condition for this reason also as well. Now, the other part that we need to know in the squint part is, or squint patients are, if the deviation is there. The deviation is more for distance or near, if they have noticed, or if it is similar. Sometimes the patient may say, look, when I'm looking straight, far, the eyes are straight, no problem. But when I'm looking close, the eyes are too much in. Or when I'm looking straight, the eye moves out. But when I'm trying to read something, it's relatively straight or less out. So this kind of information will give us if there is any disparity between or distance specific condition. Then the other part is if there is any history of squint surgery. For this question is more relevant for little older kids or little for adult patient. Like if they are presenting with a history, if there is a previous history of squint surgery. So if this is a residual or if it's a like new episode kind of thing, we need to find out that. If any glasses used or suggested, sometimes it happens like they were suggested but not used. But then also that history will important, because if we have the glasses information, that may give us some idea about the other conditions, or if the glasses will help to contain the squint part, or how much, or if it was helpful or not helpful. This kind of history will be very important. The other part on the history is again the diplopia. Now, if the squint is sudden, then most likely the person will experience diplopia, double vision. If it is, say, onset is not sudden, it was since the early childhood, the person may not feel double. They may have the alternate fixation, alternate vision kind of thing, or alternate separation, or one eye is always suppressed and that is moving out or in. But in those cases, the person may not experience the double vision. But in other cases, yes, diplopia. And sometimes it happens in the straight gaze, the person may not feel the diplopia in particular gaze. So this kind of information might be very important, like even the squint patient. Now, the other part, the patient may come with a droopy lid or ptosis. The ptosis is like when the eyes are not opening fully or as much it should be. So in this patient, we need to ask if it is monocular or binocular, like one eye only or both eyes, or if there is in both eyes, if there is any asymmetry, say one eye is more closed than the other one. Then the age of onset, like when the condition appeared first, if it was since birth or if it was later on. And if it is constant or variable, let's say the eyes are more droopy towards the end of the day, or it is the constant throughout. So there are few conditions like general health conditions. It can be fatigue, it can be, as I mentioned earlier, myasthenia gravis can give more ptosis towards the end of the day rather than in the morning hours, or when they're not tired. And if there is any associated face turn or chin position or head posture, most of the time, so if the eyes are not opening fully, we may see the person is keeping the chin little up like this. Uh, this is just a compensatory mechanism that the brain adapts and to facilitate us to see things more easier. So these things we need to keep a note. And if this changes with glasses, there are few conditions. For example, there could be some amount of astigmatism which will alter the lid position, because some astigmatism also, especially on the horizontal axis, they tend to, like when we squeeze our eyes a little bit, the vision quality improves. So knowingly or unknowingly, sometimes it happens in some patients that the eyes are not, they're not opening the eyes fully. And this kind of condition we can expect, like if it is intervened early, with the glasses used, the eyes will be more open. So this kind of information can be helpful. Then any procedure done, if there was any lid trauma or any growth in or on the lid, like there could be any tumorous growth or any nodule, this thing, or that say there was a growth and which has been removed, and after that the lid is not opening properly. All these informations are very important. Along with this, one very important part is the vision status. especially for the young adults or little older children, I'll say rather. The vision status, why it is important is, sometime if the ptosis is blocking the visual axis, in that case, the visual development in that eye may not be very proper. So earlier we can correct that part, the vision outcome will be better. So that is why this is very important to understand or get an idea what's the vision status, because that will help us. Or sometime why the vision status in the history part. Another part is, say someone is coming at like adult person who's coming with a ptosis, the vision status will give us an idea if it was since very long period or it developed later on. Because if it is since his early childhood, which he might not have noticed, or it was not that bad, but if the vision is low in that eye, that means, okay, most probably that ptosis was since long, and not the otherwise. So that's why these informations are very important in ptosis patient. Now, this is one common thing that we get. This is another, like the pediatric birth history. This is another part, the headache. Headache, we get patient in all kind of clinics, including eye, ENT, neurology. It's a very common vague kind of problem that person faces, which can have multiple causes, or in most of the cases, it's multiple causes put together. So when someone is presenting with headache or says that I'm with a headache, so I came for, say, an eye checkup. So there are some subsequent questions that we need to find out, like the headache is only in the front part or the brow region or the back, temporally. So basically, which part of the brain, head, or if it is overall or the global headache. And then what kind of headache? If it is a throbbing kind of, if it is a dull heaviness, or if it is a pricking pain kind of, because that will give us some idea what could be the probable conditions. Then the frequency, like what in this one we need to get two things. One is the when was the first time it happened, and how frequently that is happening thereafter. The other part is how long it persists. So if, say, someone says the headache comes, but like I got maybe a year back, and since then maybe after every 2 months I'm getting the headache, it remains there for a few hours, then the time of like occurrence, if the headache is more common in the morning or more common in the afternoon. Say if someone says more common in the morning, it's more likely that it will go towards migraine issues or some other issues rather than the fatigue or visual discomfort or refractive error kind of issues. Whereas if it is towards the end of the day, it can be due to muscle disbalance, or it can be due to uh, fatigue or uncorrected refractive error, or these kind of things. There are some associated factors we need to ask in case of history patients. If the patient experiences nausea or vomiting, if there is any light sensitivity, if there is any irritability or with smell or visual aura flashes, these issues are more common. Or if someone says that I'm getting flashing of light, if someone says yes, I'm not able to look at the light very properly, especially during headache, or I feel nausea kind of, these are more common with the uh, migraine kind of headaches. If someone says that no, I get the headache more after the computer use or after reading for some time, that is more related with say vision related issues or eye related issues. And someone may feel that if someone bends down, the headache increases, which is more common with the sinus issues. So this history will give us very clear or very close indication what could be the next approach we should have. Then there are triggering factors, like if it is fatigue, as I mentioned earlier, or a particular smell, bright light. Usually this particular smell or bright light kind of thing can be seen in case of migraine patient. And there are relieving factors. Someone may say, okay, if I take rest, I get better. If I take coffee, or if I take like no, nothing works, I need to take medicine. So these informations are very vital for the patient care. Now, patients with diplopia, as when I mentioned the squint part, I also mentioned this diplopia. So here we'll see little in detail, like what are the other information we need to get in the patient with double vision. Now, when someone says double, if the doubling is for distance or for close read, like near, that is one information that we need. Or if it is there for both distance and near, and if there is any discrepancy, like it is more separated when I'm looking at far and more separated when I'm looking at near, this kind of information may be helpful. And if it is monocular or binocular, sometimes the person may see double while closing one eye. So if someone is seeing double with both eyes open, in that case, most likely it is due to binocular vision issue, or the both eyes coordination issue, or squint, or this kind of factors are more associated. If it is monocular, if it is only with one eye, then it can be due to cataract, it can be due to some keratoconus patient, they may have monocular vision or this kind of conditions. Then someone may say, I don't see double when I'm looking straight, but when I'm looking right, I'm getting double. Or when I'm looking up, I'm getting double. So if it is a particular posture related or gaze related, we need to get that information. And then, as I said, the doubleness, if it is varying or if it is same, like since it started, I'm getting it is same, the doubleness is not increasing or reducing, it's same. Or it may vary throughout the day. In case of myasthenia gravis, as the muscles will get fatigued, then the double vision will also increase. So in order to treat that, we need to order the underlying cause. That is why this information is very important. Now, any associated pain. If someone says that I'm getting double and it's pain related, like with a particular gaze and there is a pain, most likely there could be some muscular growth or nodular growth, or there could be some muscle tear on the other side. There are several causes which can give this kind of response, like the double vision with the pain. And if there is a, like all other things, if there is any previous history of similar kind of thing, conditions, how that was treated, and how long that had persisted, that is very important. And if there was any history of squint or trauma, especially in case of patient with double vision. Now let's move to the other category where the patient comes for a refractive surgery. So the patient is, say, already wearing some glasses or contact lenses, but either they don't like it much, or they feel as an alternative, or they want to get rid of the glasses. In either case, the lifestyle demands that. So in those cases, we need to understand one very important thing is the profession and the lifestyle of the patient. As I said earlier, few conditions, few kind of treatment is not possible in or not suggested in particular kind of lifestyle. So based on that, the clinician will be able to decide or guide the patient better, which will end result a better patient satisfaction. Now, the use of glasses or contact lenses. So if someone is using glasses or contact lenses, how many hours and what kind of contact lens, like those contact lens related questions will come eventually for this patient. And what's their visual stability or the refractive stability in subsequent months or years? When was the last update was done? And if they're comfortable with the present correction, if not, then what kind of discomfort? Then why they're considering? First, this is very important thing, that why they're considering, if it is related with the job, if it is cosmetic, if it is freedom from glasses, or some other reason. So some conditions, as I said, like it may not be possible. So if it is only cosmetic reason is different, then the approach is different. If it is job related, or if it is that they don't want to go for the glasses, but if the other findings suggest that no, it is not possible to do the LASIK or refractive surgery in this patient, we can think of suggesting contact lens in such patients. So there are this kind of information which will help for the clinician to decide on subsequent plan. Now, any previous consultation done. Why this is important is, maybe the patient had consulted long back and then they did not do, or it was told like, no, your cornea is very thin, so it might not be possible, or there are some other conditions. or if any procedure was already done, sometimes there is a regression and we get some amount of power back, and they want to get rid of that prescription as well. So the previous history for that surgery is also very important. Then if there is a history of keratoconus or any other corneal condition, any corneal dystrophy, glaucoma, these things are very important to note in the refractive surgery patients. Now, the patient with trauma. The patient with, when someone comes with a trauma, mostly it can be an emergency kind of condition, it can be not so emergency, but the first thing that should come is when, which, and how. Like, when did it happen, and which eye or where the trauma happened, and how did it occur. Like, if it was a uh, say blowout fracture, or if something fell and hit, something was thrown at you, or you fell down, what kind of, how did it happen. So this is very important. And how is the vision after the trauma? If the vision is little blurry, or it was blurry for some time and then it got recovered, if there is any pain associated, what's the instrument of injury. Say if the person who's hit with a ball and with a, say, knife or a stick will not be same, the management and the approach should be different. So this is very important to know the instrument of injury, if it was accidental or intentional or self-inflicted kind of, at rare cases. uh, so this will help us to decide what could have happened and what could be the impact of that. And if there was any history of unconsciousness, say someone got hit with the car, or some like fall injury, and then if there was unconsciousness, for how long that unconsciousness was there, this is very important. And any primary care given when the person got the injury, if there was just a water splash, or there any medication given, or any other thing was given, any patching done, this is very important. And any previous history of trauma will also be relevant in these cases, because it can be at the same site, it can be at a different place. So say already someone had some trauma and there was, the retina was little having some issue, the second trauma may cause an RD. So if the person is having a, say, sudden loss of vision post trauma, and we can like infer, like, this is most likely there could be an RD, or there could be a lens drop. There are several causes that can give this kind of response. So that's why these informations are very important. Now, the patients with glaucoma. In patients with glaucoma, the family history is very important, and what kind of glaucoma, and if there is any medication they're taking, if someone else in the family, what kind of medication or what kind of management was done for them. Mostly glaucoma patient will be like, they will already know pre-diagnosed conditions, so they will find out, like, we can ask what was the management done before, what was the uh, IOP or intraocular pressure, then any imaging done if they have any previous reports. Now, what are the, we have till so far talked about what are the things that we need to know. Now, what is the barriers of history taking? One could be the language. The person may not be very familiar with the patient's language, or the patient may not be familiar with the clinician's language. So that can be a barrier. Gender, sometimes based on the social prospect, we may not be feel very, may not feel very comfortable to ask something, or the person may not feel very comfortable to answer to our questions. So that can be a barrier. And poor communication skills, or lack of confidence on the interviewer. If the person does not have the confidence on the clinician, or the person who's asking the questions, they may not reveal the complete history, they may not give the full thing. So we need to give, that is why we need to build a good rapport, so that we can get as maximum information possible. And the lack of awareness, the lack of awareness can be on part of the patient, on part of the clinician. The lack of awareness in part of clinician is more important than on part of the patient. Like, sometimes, why I said patient also, sometimes they may not aware. Like, we'll get patient, they will say, yeah, my vision was less, but I felt this is how everyone sees, like one eye is less. Uh, so this is also an example of it. So yeah, basically these are the part of the history taking thing that we found. Now we'll come with this. For example, if you look at this picture, the person may appear with this. In the first one, you can see there is a little redness seen in one eye. So okay, maybe there could be a conjunctivitis or redness irritation kind of issue. The other eye, they look very much similar, but if you see carefully, both eyes are not opening equally. So this is more with the ptosis. Sometimes even they don't say, based on the appearance, we can ask the patient certain questions. Like now, if say this three patient came for just a regular checkup without anything asked, what kind of questions you'll prefer to ask in this kind of patient, you think? Or what could be the case? What should be your subsequent questions if you see someone appearing like this in your clinic? Anyone? Hello?
You could ask if the parents are noticing any abnormal head posture, or if the child is watching or observing
exactly.
something in an awkward way.
Exactly. So it can be due to, as I said, like it can be due to there is a little bit of diplopia, and in a particular posture the diplopia is less, so the person takes up that. Or it can be due to refractive error condition. Or at times the kid is just for that time being is maintaining that posture, but otherwise he or she is fine. So we can also refer into the old pictures in this kind of cases, which will help to get some additional information. That's it from my side. Any questions? Hope this will help us to get a little better understanding on the history.
Thank you, Roy.
Thank you, Mr. Roy.
So these are the few references that I used for my presentation.
Thank you, Mr. Roy.
Any questions? So you will be receiving one post presentation questionnaire again, and hope that the presentation will help you to answer if you got something wrong previously. Hopefully I was able to correct that now.
Just to confirm, this post quiz will now be sent to everybody via email who's registered and
can
attended.
you increase the volume, little Sonal? I'm not able to hear you.
It's probably my rubbish microphone. Can you hear me now?
Yeah, very low, but yes, tell me.
So the post quiz will be sent to everybody via email for those who have registered and attended the session. So please complete this as soon as possible, as well as the evaluation form that will be sent via email. Once these are completed, you should receive a certificate of attendance.
Okay. Okay, I don't think there are any more questions. Thank you, guys. Thank you for being there. See you with some other presentation later on.